It's the top of the hour, so we'll get started. I'm Dia Waguespack in Houston. I'd like to welcome everyone to today's GlomCon seminar. Today we have kidney potpourri, a selection of renal biopsy cases, and we are very excited to have our speaker, Dr. Jean Howe.
Thank you very much. Okay, hopefully you can see my screen.
Yes, looks good.
Okay, thank you for spending your Sunday morning with me, and thank you to GlomCon for this invitation. I am going to be changing it up today. Rather than talking about a specific topic, I just decided to do some interesting case presentations. I call it kidney potpourri, which is my nod to my favorite show growing up, which is Jeopardy. One of the categories is potpourri. This picture right here is actually an original piece of artwork from a very talented nephrologist in the Philippines, Dr. Maylene Lyco. It's called Flower Kidneys, There Is Hope. It was actually featured on a cover of HAKD several years ago. I talked to her yesterday and she allowed me to use it for this presentation. So thank you very much. We're just going to be going through some cases today. I thought we'd just keep it nice and light and easy and breezy. I've got 5 cases. I think it should fill up the entire time. 2 of the cases are quick ones. They're pretty simple ones, but classic. And I think that it actually gives us a chance to bite on some real renal physiology. I've got 2 cases that I'm going to show you, which were actually learning experiences for me. There's morals of the story. And then I'm going to, if I have time, I'll present the last case, which is a case that I signed out. I think it was my first month as an attending, and it actually still to this day remains a mystery. So hopefully maybe some of you will be able to provide some insight because I still have not figured out what exactly is going on with that biopsy. So we will begin. I have no disclosures. We're going to go right into the first case, and I'm going to be doing this in real time. So as you know, oftentimes when we sign out a renal biopsy, the clinical information that we're provided is quite limited. What I'm going to show you today is what I was given at the time that I read the biopsy, and then sometimes there was subsequent follow-up, and I'll share that information as it evolved, as the story evolves. So the first case is an 8-year-old male with a very rare genetic disorder. I'm not going to tell you what it is because it is actually quite rare, but it is associated with global developmental delay, some growth failure rather. He was being biopsied for worsening renal function of unknown etiology. So he does have a history of severe GERD and had a Nissen fundoplication. We don't exactly know when that was, but my understanding was it was years ago, so it wasn't recent. And he has since been G-tube dependent for feeds. He was recently admitted prior to the biopsy with strep pneumonia. I know that the creatinine was normal at the time that he was brought in, and he was treated with antibiotics on discharge, and his creatinine was normal at that time as well. 6 months later, he comes into the ED with seizures, and he was found to have a creatinine of 2.56. So that's a pretty big increase in creatinine in 6 months. The UA was notable for no proteinuria, no RBC, so this is really an AKI type picture. We did note that the C3 was mildly depressed, but the C4 was normal. So this is the clinical history. I don't know if some of you are starting to think about what we might be looking for in this biopsy, but keep that in mind as we move right into the histology. So this is a low power shot of the biopsy that we received. And so just to orient you, we have 2 cores of cortex and medulla. I know that we have cortex here because these little guys here are glomeruli, and that's where the glomeruli live. And the medulla down here, the tubules look a little bit different. There's no more glomeruli. So it's actually a really nice sampling. There are about 20 glomeruli. None of them are globally sclerotic, but even at this power, you can begin to see that there's some abnormalities. The renal pathologists in this conference might see a couple glaring abnormalities right now, but I'm going to gloss over them and get to it a little bit later. Here, there are tubules here actually, and you can see where there's a lot of white here. This is luminal dilatation or ectasia. This is not normal. Your proximal tubules actually should have nice plush cytoplasm. You really shouldn't be seeing this much lumen. And at this power, if I can see that, I know that there is a background of pretty significant tubular injury, which, in my mind corresponds now to a cause for the AKI or the increase in serum creatinine. I'm going to get the glomeruli out of the way because one of the things that the clinicians was worried about was a post-infectious type picture because the kid was brought in with strep pneumonia. Didn't have any proteinuria, didn't have any hematuria. The C3 was a little bit depressed, but the C4 was normal. And you can see that the glomeruli all look like this, which is completely normal. You've got Bowman's capsule out here, urinary space, it's clear, there's no crescents. Your GBMs are single contour, there's no breaks. There's no endocapillary hypercellularity. The mesangial areas are so small that you don't even notice them. So this is a pretty normal looking glomerulus. There's no proliferative features. There's no crescentic injury. I am showing you the immunofluorescence for C3, which is essentially negative, right? So in post-infectious, you'd expect to see at least some C3 or IgG deposition. And we're not seeing anything. We're not seeing proliferative features. I'm not seeing significant glomerular immune complex deposits, including C3. So this is not consistent with the post-infectious glomerulonephritis. The main finding, again, so here's that area that I was pointing to on the low power shot, is really tubular injury, right? You see the tubules here, they're really, really dilated. You see a lot of lumen. The tubular epithelial cells are flattened. So you've got a background of pretty considerable tubular injury. Again, you can see here on trichrome stain, if a normal proximal tubule looks, let's say, more consistent with this.